was the former palliative care nurse and educator at Cipla Palliative Care and Training Center, Pune. And he is an LNAC trainer and end of life care and educational consultant trainer. He has 7 years of experience in palliative care. Now he is working as an oncology nurse at Dr. B. Baruch Cancer Institute, Guwahati. So he is a very well known person in this field. Uh, Sudip, welcome and over to you.
Thank you so much. Am I audible?
Yes, you are.
So thank you so much. And I'm very pleased to be in the platform once again. So today we'll discuss about the pain management. So I request all the participants to please keep your video on, and you please keep yourself mute. And if you have any difficulties, just raise your hand or put it your questions in the chat box. So we'll address at the last. Okay. Please confirm if you can see my screen.
Your screen is present. Please go for the yes.
Yeah. So one thing I just want to request that my network connectivity is very poor. So I have shared the screen. So if I faced any difficulty, so I have shared my slide. So you have to share your screen. Second thing is that I will keep my video off.
Okay, sir. Noted.
Okay. So before going to the pain management, we have to understand the pain. So all of you can understand English? Yes?
Yes, sir.
Okay. So we have to understand the pain as a gross. So I think in the previous 2-3 sessions, you have already understand that palliative care has the four main pillars, that is physical, psychological, social, and spiritual, which combinedly told as a 4 components. So as pain also has the 4 components: physical, psychological, social, and spiritual, which all together is known as the total concept of pain. Total pain. Okay. Next, if we see the principles of pain management, so our pain medication has to give by the clock, by the ladder, by the class, and attention to details. Now, what is by the clock? So if we see that by the clock, so sometimes what happened, maximum of the patient, they used to come to our OPD, or they used to come that they are not taking the medication on time. Sometimes if they have pain, then only they are taking, or they have some needs that if I continuously taking my pain medications, I will be having my kidney function impairment. That is one. Second thing, sometimes it happens also for our healthcare workers that sometimes the one patient, if he or she is having any pain medication at late night, suppose 11 p.m. So sometimes patient attendants came to you, oh sister, actually my patient is having one tablet at 11 p.m. So now it's 9:30, but my patient wants to get sleep early. So can you please give the medication little early? So sister is so kind. So sister will give the medication at 10 p.m. sometimes, and she will sign on 11 only, because she has given the dose. No, so she has signed on the 11. On the next morning, if nobody tells the actual history, if the patient is having much pain, then they have to give the injection, they have to give the emergency drugs, emergency pain medication drugs, and of course it will misdirect the medical team to increase the dose or to change the medication. So we have to give the medication by the clock. Whatever the doctor have already been prescribed, we have to give the dose as per the prescription. Next is by the ladder. So we will talk about WHO analgesic ladder. So we have to maintain the ladder. Whatever ladder says, we have to give the medication as per the ladder. We'll talk more about that. Next is by the class. What is by the class? So there are three different classification: non-opioids class, opioids class, and adjuvants class. So non-opioids and opioids, whatever the classes, the medication we are using, we should use is very promptly, and all the medication side effect we should be like keep in our mind, and two same class medication we should not use at a time, so that the patient should not develop any kind of side effects. Next is by the mouth. Why? Because oral route is always the preferable route for the patient. But if the patient is actively vomiting or sometimes unable to take the medicine because of the drowsiness, or the patient is unconscious, or significantly they have the GI dysfunction, or they have the difficulties in swallowing, then we can give the medication like subcutaneous, intravenous, intradermal, that we all practice day-to-day basis. What is attention to details? This attention to details is that sometimes whatever the dose is already been prescribed for the patient, so this is already okay, and this dose is basically perfect for the patient. But there are some other factors like because of anti-cancer treatment, so they are getting side by side, they are getting neuropathy, or their nerve is damaging, and because of that the additional pain they are like they are experiencing. Sometimes they do not want to change their position, and the caregivers are not able to change the position frequently, and because of that they are facing like they are suffering from pain. And so these kind of things, that small things which of course give the give a more impact on the pain management, so we need to look into that matters. If we see the pain management, so there are two main aspects, that is non-pharmacological management and pharmacological management. Now, so many of we have, maybe you are having questions that what we should use, the or pharmacology first or non-pharmacology later on. So this kind of like things happen. But I like to say that suppose you want to shift a very heavy materials from one place to another place. So if you try one single person, it will be it might be very difficult. But if you take someone's help and both of you give your effort at the same time, then both of you can easily change the metal. So there we should use the pharmacology and non-pharmacology in the same time, so that we will get the most or like maximum effect, good effect from the drug and the for the pain management. So next is the what should we teach the family to prevent pain? Maintain the stable analgesic blood level. So whatever the doses and the frequency has been prescribed, they have to give the medication on the time, on the particular dose, and on the right manner, so that analgesic drugs in the blood plasma level, it should be maintained, and the background pain should not be there. Next is the like individualized to the pain. Sometimes what happen that family members, they think that okay, right now only 1 hour before I have given the pain medication, so my patient's not supposed to get the pain, but he is complaining of pain. That means he is just making us full, and he is just want to get the sympathy and all. So we should not individualize. If the patient is saying that he is suffering from pain, that we need to believe, because pain is the subjective sensation only. It cannot be objective, because if I am having pain, that you cannot see my pain, only I am the one who can feel the pain. So individualized, the pain has to address individually, whatever the severity the patient is like suffering from, then as per that level we have to address the pain. And frequently assess the pain, and we have to keep on adjusting the treatment plan and change the treatment plan as like patient requirement. Now, before going to the pharmacological, I would like to talk about non-pharmacological therapies that we all know, like physiotherapy, exercise, hot and cold application, meditation, music, distractions, and sometimes massage, homeopathy, ayurveda, and home remedies. Like sometimes it happens that okay, it pain, but not you. If my mom give me massage, her massage is so effective. So this kind of like home remedies and sometimes some psychological things also works nicely. But non-pharmacological, we have to use such manner that we patient should not deny it. Sometimes, like see, if the patient's pain is very high or patient's severity of pain is very high, and in that time if I ask them, okay, you please listen to this music, it will distract your mind and won't feel pain, the same time patient will just kick me out. So that time we have to understand the thing, when should I introduce the non-pharmacological therapies and what non-pharmacological therapies I should introduce at the what time. And so these are the things on the basis of situation we have to practice. Okay. Now this is the pharmacological management of pain. So World Health Organization has given us a ladder and for the cancer pain management or palliative care pain management. So it has basically 4 steps. Step 1, it's named as non-opioids, and you can see that there is plus minus adjuvant. Adjuvant I will talk later on. Okay. The step 2, it's called opioid. It's of course a mild opioid, and plus minus adjuvant or sometimes plus minus non-opioids. Step 3 is called the strong opioids, and it's of course it can be combined with the non-opioids and also adjuvant. Now, step 4, what is step 4? Most of the hospitals, they used to practice this step 4. It's called the interventional pain management. So interventional pain management, for interventional pain management, like patient need little bit of like fitness. Okay. So they have to undergo some nerve block procedure. And because of that, they need they need to have some physical fitness in order to undergo this procedure. So if they do not have that fitness, so the same procedure will not be effective, or the anesthesiologist cannot able to apply the same process to the patient. So in that time, like in case of palliative care patient, most of the palliative care patient, they are malnourished and they are not fit most of the time. So step 4 is not that important for palliative care, but of course in the initial stage of the patient diagnosis, of course if the facilities are available, then they can definitely use. Now today we will discuss about the step 1 and step 2, and step 3 we will discuss in the next class. Now, before going to that step 1 and step 2, there are little drawbacks of the WHO analgesic ladder, which is it only helps to treat the physical component of pain, because if you have already seen that I have mentioned that total palliative care patient or the chronic illness patient is having the 4 components of pain, which all together says then total pain. So they have the physical, psychological, social, and spiritual. From the all component, WHO analgesic ladder helps to treat the physical component only, not talk about the other 3 components. But the thing is that they believes that once patient feel okay, and physically the patient is okay and there is no pain, through counseling and repeated counseling, we can address their other 3 components of pain, of course. So WHO analgesic ladder is granted as a best management of pharmacological management of pain. Now, you have seen that step 1, it was named as a non-opioid. What are the drugs? Can you please write it in the chat box? I'll ask everyone to please write some step 1 drugs in the chat box. Paracetamol, very good. Next. Paracetamol and any other drug. There are so many drugs. Ibuprofen, very good, very good. Any other drugs? Diclofenac sodium, very good. Acetaminophen and paracetamol is little bit same only. Ultracet is not in the non-opioids. Zerodol, please don't write the brand name. Try to write the pharmacological name. Tramadol is not the non-opioid. Zerodol is the combination of paracetamol and the aceclofenac. So diclofenac and aceclofenac. Voveron is diclofenac. So, okay. And any other drugs you can remember? Very good. Any other tablet? Myospas, okay, okay. Celecoxib, okay. Aspirin, very nice. Any other? Any other drugs? Okay, okay, very nice, very nice. Okay, so we'll discuss more. So basically paracetamol, ibuprofen that you all have written, then all kinds of NSAID. So if we say that all kinds of NSAID, diclofenac, aceclofenac, etirocoxib, maybe lorazepam, so this kind of NSAID will come, all kinds of NSAID, and antispasmodics also come under that. Okay. All NS acids nahi hai. It's not all NS acids. It's NSAID. Okay. NSAIDs. All NS acids nahi hai. Okay. Okay. So for non-opioids also there are little side effects. Like paracetamol and NSAIDs, they have little side effects. One thing is that if the patient has some bleeding disorder, so NSAIDs, it's improve the bleeding tendency, increase the bleeding tendency. Okay, so if the patient has some bleeding tendency, this kind of patient, we should avoid NSAID as much as possible. If the patient is getting paracetamol for a very long time, maybe 3-4 years at a time, like continuously, then liver function impairment or NSAIDs sometimes affect the kidney functions as well. So we need to keep in mind those side effects when we are administering the drugs to the patient. What is our nurse's responsibility while we are administering the step 1 drugs? Like periodical reassessment need to be done, like how effective our treatment is. Okay, next is if the patient is getting the 2 different kind of NSAID at a time, that we need to inform the doctor that this patient is getting 2 NSAIDs at the same time. So these kind of things should not be happen. This is our nurse's responsibility to inform the doctor that maybe unfortunately they did not notice the thing, but the patient is getting 2 NSAID drug at the same time. Next is if the patient has any history of kidney function impairment before, or if I get like any previous reports, now their reports is okay, but sometimes when we are continuously dealing with the patients, we may come up with some previous reports where creatinine urea is very high. So we should inform the doctor that this patient, their kidney function impairment was there before, so we should just keep in mind. Then liver function impairment patient also, if we got such kind of patient, or if they have any history previously, then we should bring in the focus of the medical team so that their medication can be adjusted nicely. If the patient has the bleeding disorder that I have already mentioned, and we need to highlight the things. Now come to the step 2 drugs. Now you please write what are the step 2 drugs. Chat box, I'm waiting in the chat box. Tramadol, very good, very good. Codeine, very good. Not morphine, not morphine. Step 2 is the weak opioid. Step 3 is a strong opioid, and morphine comes in strong opioid. Okay, so morphine will be coming in the step 3, which we will discuss next class. Now step 2, weak opioids, it will be tramadol. Yes, dihydrocodeine, codeine, dihydrocodeine, tramadol, tapentadol. These 4-5 drugs are there in the step 2. Thank you so much. Now, what are the things we need to remember while we are giving any kind of step 2 drugs to our patient? Sometimes it happens that patient is already in the NSAIDs and they have step 2 drugs or injection tramadol, SOS. Okay, SOS, it's not mean that the number of time, if the patient is getting pain in the so many number of time, then every time the patient complains of pain, I just give one tramadol injection. That we need to keep in mind that step 2 drugs have the certain limit, or they have the ceiling effect. Ceiling effect means they have some limitation to use. If like for in case of tramadol, if we use more than 400 mg, it won't be effective for the patient. If the patient won't be able to get the good effect, rather than getting the good effect, patient will get more side effect. So step 2 drugs we have to use within the limit. If we are not using within the limit, or the patient pain is not managing by using in the limit, we should inform to the doctor. We should go to the doctor to change the medication or to reschedule the medication as well. Second is, step 2 drugs should not use, like two step 2 drugs should not use at a time, so that, like as I have mentioned, so that the patient should not develop any kind of side effect. Next is, step 2 drugs should not use with step 3 drugs. So step 3 is a strong opioid, step 2 is a weak opioid. Just imagine, in a ward you are working and there is one ANM sister and one is MSc or PhD level sister. Now ANM is working for a very long time, she is working and she is little experience also, she is working nicely. Now MSc, she or MSc or PhD sister, she is little bit concerned about the quality. So if she try to put or try to like put pressure on the ANM system, no, you have to maintain this quality, that quality. So apart from taking care of the patient, they will just fight among themselves. So if you give step 2 drugs and step 3 drugs at the same time, they have the agonist and antagonist effect. They have the agonist and antagonist, so they just fight among themselves. Just for example, just to make you understand, that they fight among themselves, but none of them will take care of patient's pain. So we should not use step 3 and step 2 drugs at the same time. Next is, step 2 drugs should not be used for the children below 12 years of age. So I think you have encountered that, like step 2 drugs. So in order to metabolize those drugs, the patient's kidney, patient's liver need to be developed properly. As we know that the children below 12 years of age, their organ development sometimes it's not properly done. So we should not encourage to give step 2 drugs to the children below 12 years of age. But sometimes in some cases, that if the child is hypersensitivity to morphine or hypersensitivity to some of the opioid drugs which is available in the hospital, or maybe this hospital do not have the license to procure the strong opioids, then step 2 drugs can be used SOS basis only in some circumstances. Okay. Now, what are the nurse's responsibility? So they should use within the prescribed limit. If then also the pain is not properly managed, we should inform to the doctor. We should inform to the on-duty doctor. 2 same class drugs should not be used at a time. Okay. Next, every patient should be assessed for common complications of weak opioid like constipation. So this also a opioid, morphine also a opioid. Both are the things opioid only. One is weak opioid, one is strong opioid. But different studies have already been published that there is no difference, not so difference in the severity of constipation in case of weak opioid, in case of strong opioid. Approximately the severity of constipation is same only. So we should think or we should ask about any kind of bowel regimen while we are or while the doctor is prescribing weak opioid or step 2 drugs, because opioids, this is a centrally acting drugs and it reduces the peristaltic movement on gut mortality, and because of that the patient is very high risk to develop constipation. So they need bowel regimen in order to get rid from the constipation. Now come to the neuropathic pain. What do you mean by neuropathic pain? Can you please write what do you mean by the word neuropathy? Pain that derived from the nerve compression. Okay, nerve pain, pinprick pain. Okay, nervous related. Okay, thank you so much. So just go to the constant ache. Okay, you are partially correct. All of you are partially correct. Basically, if I just simplified the word neuropathy, pathy means damage, neuro means nerve. So because of nerve damage, it can be because of compression, it can be because of medication, it can be because of any other things. But when the patient is developing pain because of the nerve damage, it called the neuropathic pain. Okay, then how we should understand the patient is having neuropathic pain? By taking history, by taking proper history. So basically neuropathic pain, they will explain that it's like radiating from one place to another place. Sometimes they have experienced the pain like burning sensation, tingling sensation. So this kind of pain experience they will have and they will explain in such a way. So how we should manage? So basically massaging, hot and cold application depend on the site and the patient like and dislike. Next, antipsychotic and anti-epileptic drug. So sometimes like antipsychotic and epileptic drug also. So if some of you may already know that neuropathic pain can be managed by pregabalin, gabapentin. But if you Google or if you go to the drug book, if we see the action of gabapentin, it is basically an anti-epileptic drug, but it also works on the neuropathy nicely. So anti-epileptic drug and antipsychotic drug, sometimes SSRIs, this tryptophan 25, this kind of drugs, it's also helpful to reduce the neuropathy or neuropathy kinds of pain. And sometimes other home remedies like massaging with some oil, massaging with some like other things, and can be like different positioning, yoga, this kind of things can be helpful. And physiotherapy has a very much effective treatment on neuropathic pain. Yes. This amitriptyline is very nice. This tryptophan, what I have seen, I have told you that is amitriptyline only, amitriptyline 25. Now, the people has the like might be having question. Okay, so we have understood the step 1 and step 2. Now, which step we should use when? So, depending on the severity of pain, mild pain when in the numerical rating scale, if the patient pain is 1 to 3 in numerical rating scale and it is 0 to 10, no, I think all of you know, 0 is no pain, 10 is worst possible pain, ekdam rone wala pain. Okay, that worst possible pain, and among them, if the patient pain is 1 to 3, then step 1 can be very useful. If the patient is having moderate pain in numerical rating scale, patient pain is 4 to 6, then can be step 2 can be very useful. And next is severe pain. In case of if the patient is having pain to the 7 to 10 in numerical rating scale, so we can transfer to the, or we can shift to the patient to the step 3 and so on. Now, adjuvant can be used on the basis of pain pathology, pain physiology. So like now, who can tell me that what is an adjuvant? What is an adjuvant? Can you please type additional? Very superficially, can you please like write it little deep? Please try. No worries. If you are doing anything wrong, I'll correct it. But let me just know that how you know. The add of medication to L with the pain control. Okay, very nice, very nice. Anything else? Anyone wants to restructure the Zafar Nurul, whatever he has given the answer, it's correct only, but anybody wants to like restructure that sentence? Okay, let's move to the next. So basically, adjuvant is the drug which do not have the primary effect on the pain management, but it helps the efficacy, it helps to increase the efficacy of the primary pain medication. Okay, suppose now I am giving you an example. Suppose the patient is having CA ovary, cancer in the ovary, and there is huge mass in the abdomen. The abdomen is getting very big. Okay, that time the patient is compressing the bowel and patient cannot pass stool for a very long time. We are giving morphine, we are giving tramadol, we are giving morphine, then we have shifted to the morphine and we are continuing with morphine. Patient is getting drowsy, but still patient is telling that I'm having pain, I'm having pain. So now doctor has prescribed corticosteroid. Doctor has given the high dose of dexamethasone or hydrocodone. Then it helps to reduce the or shrink the tumor for a little period of time, and then bowel is getting space. Then all the fecal materials is passing out, and patient pain go away. So now corticosteroid has no effect on pain, but it has little effect so that it increases the efficacy of morphine. So here corticosteroid is the adjuvant drug, morphine was the primary drug. So corticosteroid helps the morphine to act properly. Are you understanding? Yes. Steroid to reduce the periedema of the tumor, so that yes. So adjuvant is the drug which is not directly effect on the pain, but it helps to increase the efficacy of the primary pain medication. So let's once again, we will talk about the non-opioid drugs. It's the paracetamol, ibuprofen, diclofenac, naproxen, aspirin, and eterocoxib, nimesulide, ketorol, and all kind of like antispasmodics. It's all come under non-opioids. If we see about the weak opioids, it's like tramadol, codeine, dihydrocodeine, and oxycodone. And adjuvant drugs, antipsychotic drugs, antidepressant drugs, which is and anticonvulsant drug, which is also useful for the patient to reduce the neuropathic pain, and also it's anti-anxiety, like reduce the patient anxiety and reduce the patient other like components, helps in the reduce the other pain component as well. Okay, now before going to the like ending, there is one thing, it was in the slide of WHO analgesic ladder. Like, you can see that non-opioid plus minus adjuvant. So you have understood adjuvant, you have understood non-opioids. If you go to the step 2, if you go to the step 2, like here it's mentioned that step 2 plus minus non-opioids plus minus adjuvant. Adjuvant you all have understood. One of you have given the answer that Ultraset. If we see the Ultraset tablet, so it's the combination of paracetamol and tramadol. How much of tramadol? Tramadol is 37.5 mg and paracetamol is 325 mg. It togetherly comes as a step 2 drugs. So the step 2 drugs, that's why it's some very few times it's come alone, that tramadol alone it's coming, but in market it's available plus with paracetamol only, and paracetamol is a non-opioids. That's why here plus minus non-opioids is written. I think all of it's clear for you all. Now, if you have any query, we'll just address this query and then we will go to the case presentation. If you have any query, you please put it in the chat box, or you can unmute yourself and you can directly talk about that. Any difficulties, please put it. It's adult learning is a give and take process. It is not mandatory that we know everything. Okay, so if you are not knowing or it's new for you, if it is not clear with you, you just write it in the chat box. I'll explain once again so that everybody will be clear. It's the foundation. Foundation has to be very strong.
Thank you, Sudip, for the wonderful session. Anybody have any questions on this? Please ask him, or you can put that question in the chat box. Anybody? I hope your class is clear to everyone.
If they do not have any questions, I have one question. Please write the answer in the chat box. Okay. In history, if the patient is having neuropathic pain, what in history, what kind of pain they will explain for? Like how you will explain the ask the patient about the pain history. Like you have understood that the patient might be having the neuropathic pain. How you will diagnose that patient is having neuropathic pain? How? Your history taking only confirm that this is neuropathic or nociceptive. Now, how you will understand? Tingling sensation. Okay, history of tingling sensation. Okay. Okay. Numbness, pricking pain. Sometimes it's a burning pain. Okay. Yes, score can be very severe and yes, burning feel. Okay, very nice, very nice. Yeah, Shiva, can we move to the case presentation then?
Sure, sir. We can move on to the case presentation.
Thank you so much all, and I think see next date 1st December also I have class on the strong opioids or step 3 drugs opioid class. So if you are facing any difficulty in this class, you can ask them, because I don't want you to be in the doubt and complete your foundation course.
Thank you, sir.
Okay. Yeah,
Please,
so we
please
can
continue,
move on to
Shiva
the
ma'am.
case presentation. Supriya will be presenting a patient story. So Supriya, so to you.
Hello, good afternoon, everyone. My name is Priya Guru, and I'm working as a staff nurse at District Hospital Gazing. Today, I'm going to do a case presentation on respiratory system. So, a patient aged 60 years, male patient, which was later diagnosed as interstitial lung disease. Next, presenting complaints was cough for last 1 month, shortness of breath for last 1 week, and mild chest pain for last 10 days. History of illness was it was gradually onset and little progressive. It was harsh, forceful, vigil, and infrequent bouts. It was persistent throughout the day, but it was more at night. Pain was located mostly over anterior chest. Patient was having weight loss, malaise, muscle pain, headache, shortness of breath, and loss of appetite. Examination was also done for this patient. So under vital signs, blood pressure was 120 by 90 mm of mercury. SpO2 was 84 under room air and it was 98 with oxygen. And pulse rate was 116 beats per minute. Respiratory rate was 24 breaths per minute and temperature was 98.4 degrees Fahrenheit. Treatment and significant investigations. Under treatment, oxygen therapy was given. Head elevation was done for this patient. Humidifier was also used. Patient was kept in a propped up position and patient was encouraged to drink plenty of fluid. And antibiotic, antipyretic, antiemetic was also used. So under investigation, So under medication, injection amoxicillin 1.2 gram IVPD was given. Injection Pantop 40 mg IVOD was given. Injection on them 8 mg IVSS was kept. Injection hydrocort 100 mg IVTDS was given. Syrup Rapidos 10 ml for oral TDS was going on. Neb Diolin TDS was on. Neb Buticot TD and syrup Rapidos 15 ml HS and tablet PCN SS. On psychological aspects, he was a school pupil and his wife died 5 years ago. He was feeling so lonely. He was operated because he was continuous O2 because his saturation was not maintaining under care. So he was operated if he has to be on O2 max lifelong and pain he was going through. Next slide. Main concern, financial aspect, self-care, fear and anxiety due to this condition. A summary. Patient aged 50 years, male was admitted with the chief complaints of dyspnea, mild chest pain and cough, and which was first 2 to 3 days after admission was continuous O2, but after that he was little maintaining on the room air. Sometimes he was like his saturation was fluctuating, so O2 was kept intermittent. All investigations was done, vitals was checked and recorded, ECG was done, chest X-ray was done, ultrasound was done, treatment and medications were followed up. And for this patient, general and physical examination was also done. Sputum CBNet was also done because he was also under quiet pulmonary. He had one episode of fever before 1 day of his admission. Only saturation was not under was not fine under lunar, but he was doing better than before. On the discussion point, how can we provide better palliative care for this patient and how to manage pain for this patient? Thank you so much.
Okay, Supriya, thank you very much for the wonderful presentation. Anybody have any more clarification regarding this? Please ask her, otherwise we can move on to the discussion points. Sudip, over to you. Sudip, sorry.
So basically one question is how can we provide the better palliative care for this patient? So this patient, if we see the patient and the family as a whole, the four components, so we have to keep the patient in the four components: physical, psychological, social, and spiritual. So physically, patient is worried about that he doesn't want to be on oxygen for a very long time. So there, like we can review the medication, we can the necessity, like review the necessity of the oxygen, uh, like importance of oxygen. And while oxygen, if he is not liking the mask, then we can put the nasal prongs instead of mask, which will allow the patient that while oxygen is going on, that time even patient can talk with the patient like regarding his needs, what he likes or dislikes. Okay. Next is like patient economic condition. So then we have to discuss the patient earning person, who are the earner for the family, and how he or he is managing the like medication bills and other bills, and then what is the other income source for that particular patient, so that according to that they are. Yes. So there are different schemes, governmental schemes. We can help the patient to meet the social worker who can help them to apply in the different schemes where their social things can be addressed. Psychologically, if the patient is depressed and fear about the prognosis and about how he will manage the like regarding the disease progression, then the repeated counseling can be helpful for the patient. And also that time, like medication need to be little, because we have seen, I'll just combinedly answer the both the things, how we'll going to like manage the pain as well, because I have seen them in the medication. We can put the, some of the medication for the pain also, but there is only PCM. PCM is not that much effective maybe for the chest pain, because if he is he is having the coughing for a very long time, because of that, if the patient is having like chest pain, that time physiotherapy can be more helpful along with the other treatment. So physio chest PT can be helpful to expectorate the patient's secretion. Second thing, in that time, opioid class, whether it is weak opioids or strong opioid class of drugs will be more effective, because if the patient is not having the severe pain, maybe the hospital will not put him in the strong opioids. But if the patient strong opioids has the good effect on breathlessness also, and so low dose of strong opioid can be helpful, as like Zafar has already mentioned that morphine can be helpful. Yes. So if the patient is already on morphine, then we can increase the morphine by 20 to 25% for breathlessness. If the patient is not on morphine, that time we can start the patient on maybe low to low dose, that is 2.5 mg we can give, and we can observe the patient for 4 hours. If it is giving the good result to the patient, then we can continue it, or else we can change the other medication. And third is, we cannot give this patient NSAID because he is having breathlessness, and NSAID increase the breathlessness, because NSAID increase the bronchospasm, and through like through does it increases the breathlessness of the patient. So breathlessness patient, we should avoid the NSAID. So NSAID we cannot give. And if strong opioid is not available in the particular hospital, so they can try with the weak opioid. Sometimes it helpful. And also repositioning the patient, and it will helpful. And sometimes we can some other non-pharmacological measurements like massaging, like we can chest PT. Sometimes we can ask the patient not to talk much, because what happen in the villages when any patient is suffering from a chronic illness, so many family members will come and repeatedly they will ask, oh, how you got this disease, what happened to you. So patient is very tired of explaining the same thing to the every relatives. So these things we should ask the patient to avoid, so which will improve the patient's like prevent the patient from breathlessness. And also for the breathlessness, like um, fan on face, huh? Not in the high speed fan, of course low speed fan on the face, it will be helpful along with that. So this patient for the like breathlessness and as well as pain, I think opioid will be the good option for this patient, because we cannot give the non-opioids at like the patient is having breathlessness. So this in this case, like opioids class drug will be showing more effectiveness than anything. So this is the only. Any other questions if you have, please put it in the chat box.
Sir, shall we use incentive spirometer in this case?
See, if you can, like, if you go back to the patient scenario, patient is having the SpO2, it's 84 or 80% only. In such condition, if you ask for respiratory, like respirometer, then he will get more breathless only. In this case, we should not encourage the patient for respirometer, using of respirometer.
Okay,
Patient
thank you,
has
sir.
to, yes, patient has to be stable first, but they here whenever the patient is in long term disease condition, then we have to see the patient quality, not in the quantity. So patient quality of life. So in such condition, if we are putting the oxygen masks, of course the patient will be able to communicate with the healthcare workers, not able to communicate with the family members, not able to communicate with the friends also. In such condition, we can provide nasal prawns instead of like mask,
Yes,
which
sir.
will even keep the saturation nicely, and also patient will be able to explain which he wants to explain.
Sir, along with the nebulization, is steam inhalation may helpful?
Yes,
Along with the nebulization.
yes. Steam inhalation can be helpful, but the thing is that in the time of steam inhalation, patient has to take the oxygen as well, because if he is not taking oxygen that time, he will get more breathlessness.
Okay, thank you, sir.
Yes. If this will come under the home remedies, okay. Of course patient can explain, patient attendants can give and patient can use, no issue, but it will depend on the, of course depend on the patient comfort. If the patient is having comfort, then he can definitely do it. And after like doing the first time, if the patient is not getting proper relief from the breathlessness, then of course patient won't be able to take, or patient do not want to take. So at that time we need to consider it. It is not that we feel that it will be helpful that we have to impose and patient has to accept it. If the patient is not getting benefited, then patient can like ignore the same thing. Any other questions?
So, Sudip, I just want to add few points. So, regarding the management of breathlessness, always when a patients come to you with a breathlessness, as the nurses, we always try for a non-pharmacological management first, and if that doesn't help, then you can go on to the pharmacological management. And if you try on oxygen, so after 10 minutes, you have to talk to the patient whether that oxygen is helpful or not. If
Yes.
it is not helpful, you have to remove it. And also, you have to think about the nasal prongs. As Sudip mentioned earlier, always you have to think about the nasal prongs instead of mask. So if you apply mask, the communication will be restricted. So it's very difficult to manage with mask. So the nasal prongs is very comfortable for them. And the another thing is the reassurance. So reassurance is also is very important. And and you have to educate the patient about the deep breathing exercise, because if they have breathlessness, they don't take deep breath, they take breath and out. So that
Yes,
again
superficially
is
that.
superficially. So you have to talk to them, educate them how to take a deep breath, and you have to give that reassurance. You have to tell them that we are here to help you, don't worry. So that kind of reassurance is helpful for them, in the patient as well as the caregivers. That is very important. And also you have to think about the opioids also. The short the dose of the mild dose of narcotic is also can helpful to reduce the shortness of breath. If the patient is not on opioids, you have to start on 2.5 milligram, as Sudip said earlier. So that will be helpful for the shortness of breath patient. And handheld fan. So that is also the new that articles came like that. New studies came like the handheld fan is helpful for relieving the shortness of breath. So that will you if you do that, that will stimulate the trigeminal nerve, and that because of that, that patient will reduce the dyspnea. And definitely this patient need palliative care as so you have to think about the patient family also. You have to educate the family members how to take care of the patients. If maybe if the patient is in the home itself, if they have developed, if the patient has developed dyspnea, you have to prepare the family members how to reduce dyspnea, how to, yeah. So
Yes. Here actually the major role will be taken care of like by good communication skills, and good communication will manage the maximum of the case scenario. Like what happened that Madam already mentioned, Shiba Madam already mentioned that how effective the oxygen is, that we need to keep in mind. Like when sometimes what happened, the patient is having the saturation of 86 constant, and if we are giving oxygen 2 liters, then 3 liters, 4 liters also, it's getting only 87, 88, but it is not getting more than 90. So in such condition we should not keep on increasing the oxygen. We just, okay, to keep the patient calm, not to give the patient will feel anxiety, no, but there is no oxygen, oh I'm not, I'm going to get like I'm going to die now. So in such condition we just keep just the low dose of oxygen. In the same time we'll side by side we'll try to counsel the patient, counsel the family members, that along with the patient they should not feel breathlessness, and it will help to keep the resources nicely and keep the like patient not to feel more burdened with the oxygen and all those things. And so here good communication is more important, so we every now and then we should keep on contacting the patient family members, close relatives, and also directing the patient.
okay. Thank you. uh, Also, so we have learned about the management part one, the NSID adjuvants and all, so non-opioids and all. So step one, we learned about non-opioids and NSAID. If you give NSAID, so that is the NSAIDs are the they are block the production of prostaglandins, so that we can inhibiting the inflammation. Okay. So we are not authorized persons for prescribing medications, but uh, we have to have some responsibility after taking that medications. We have to assess properly. Better assessment is needed for effective management. So here, when they come to you for a review, you have to assess whether they have any side effects, because the gastrointestinal, the most common problem is in the gastrointestinal ulceration, renal dysfunction, platelet inhibition. These are the three common problems that patients can occur after NSAID. So what is our role? So we have to educate them. After taking food only, they have to take NSAID, and also they should take enough adequate water, and also maybe proton pump inhibitor. So gastroprotective drug, that medication also they should take. So these three important instructions you should tell them. They should take medication after food. They should take plenty of oral fluids so that all the toxic effects will excrete out, and also they should take some proton pump inhibitor that will protect the gastric mucosa. Okay, so that is one important message you have to keep it in mind. And moving on to the second step, uh, weak opioids. Sudip had given a detailed information about the weak opioids. So one important thing you have to keep it in mind is, the tramadol will reduce the seizure threshold. So you have to think about, if you give a medication to the children, so you have to be cautious. It will reduce the seizure threshold. Okay, and the another problem is side effects. That also Sudip has mentioned, the constipation. It will reduce the intestinal motility, so that we need to give a stimulant laxative so that we can give prevent constipation. Okay, and the third part is adjuvants. So the adjuvant is not a prime that adjuvant drugs is not, in the primary aim is not an analgesics, but it can helpful in some painful situation. For example, neuropathic pain. We have learned about two different types of pain: nociceptive pain and neuropathic pain. So neuropathic pain, we usually use tricyclic antidepressants. So what is the role of tricyclic antidepressants? Those who are in the depressive disorder, we used to give for the psychiatric medication. We used to give the amitriptyline and uh, that kind of drugs. Okay, so imipramine and amitriptyline. So that particular drug, it can be helpful in some painful condition. So neuropathic pain, that is what we call it as adjuvant. And also Sudeep has mentioned about the corticosteroids. The corticosteroid, what is the aim of the action of corticosteroids? So it will reduce the inflammation. But here it will reduce the peritumor edema in palliative care. So if the peritumor edema is reduced, definitely the patients will get some kind of relief. If the inflammation is there or peritumor edema is there, the pain will increase. The visceral pain will be there. So if the peritumor edema is decreased, the pain will subside. So that is why we call it as adjuvant. Okay. So adjuvant is not a the main primary aim is not a painkiller, but it can be helpful in some painful condition. Okay. So I think this is the short summary about today's class. Uh, Rest of the part Sudeep had mentioned clearly.
I was too fast or too slow?
No. It was clear. It was clear.
Okay.
Okay. It was an excellent session.
So if you have any difficulties, though the actually discussion point is shifted to from the pain to respiratory depression, of course, but altogether it was a nice discussion as well. So we'll learn more in the